Welcome to the new Heart Failure NICE 2025 update in just 10 minutes. We're going to compress what used to be a 50-minute lecture into high-yield exam-ready essentials. By the end, you'll know the new 4-pillar framework, the ARNI rules, and which drugs are safe and unsafe in heart failure. Let's dive in. NICE guidance was updated in September 2025 with big changes to treatment algorithms and monitoring requirements. In practice, this impacts every clinician who sees heart failure patients, from primary to secondary care. Exam critical phrase, heart failure remains one of the highest weighted topics in pharmacy exams. That's why mastering these updates is non-negotiable for both practice and assessments. Let's look at how heart failure presents and how we start to investigate it. First, symptom recognition. The classic symptoms are shortness of breath, fatigue, ankle swelling, and reduced exercise tolerance. In real life, patients may just tell you they're getting more breathless going upstairs or that their shoes feel tighter at the end of the day. These are the red flags that should always prompt a systematic assessment. Exam critical phrase here, recognizing those early warning signs. Second, initial investigations. Once you suspect heart failure, you move to the basics, chest x-ray, ECG and blood tests. The chest x-ray helps us see pulmonary congestion, the ECG can reveal structural or rhythm abnormalities, and the blood panel should include NT-proBNP. Buzzword to memorize, NT-proBNP is the biomarker of choice in suspected heart failure. And finally, NT-proBNP interpretation. Now, this is one of those high-yield numbers you must know. NT-proBNP stands for N-terminal pro-B type natriuretic peptide. In simple terms, it's a hormone released by the heart when it's under stress. Think of it as the heart's SOS signal. The higher it goes, the more likely heart failure is present. Thresholds to remember: if NT-proBNP is above 2,000 nanograms per litre, you refer urgently. The patient must be seen within 2 weeks. If it's under 400, heart failure is very unlikely in clinical context. So the takeaway from this slide: spot the symptoms, order the right tests, and know your NT-proBNP cutoffs. Those numbers are both a clinical lifeline and an exam favourite. Now let's move on to the non-pharmacological side of heart failure management. This is often overlooked, but it makes a huge difference both in practice and in exams. First, lifestyle modifications. We're talking about smoking cessation, cutting down alcohol, structured exercise, weight management, and reducing dietary salt. These sound simple, but they provide a substantial clinical benefit. High-yield phrase, lifestyle measures reduce admissions and improve long-term outcomes. In practice, this is your starting point with every patient. Second, daily monitoring. This one is critical for patient education. People with heart failure must weigh themselves every day, and here's the buzzword to memorize. If they gain 1.5 to 2 kilograms in just 2 days, that's fluid retention, and they need to seek medical help urgently. This advice alone can prevent hospitalization. Third, preventive care. Infection is a common trigger for decompensation, so vaccinations are essential. Annual flu jabs and pneumococcal vaccines significantly reduce the risk of deterioration. Exam tip: always link heart failure management to vaccinations. It's a favourite test question. And finally, rehabilitation and education. Structured cardiac rehab programs combine exercise with education, and they really improve adherence, confidence, and quality of life. Think of it as equipping the patient with the tools to manage their condition every day. So the takeaway: these 4 pillars of non-drug management, lifestyle, monitoring, prevention, and education are as vital as the medicines. In both exams and real practice, don't miss them. Now let's move on to the real game changer in the new NICE guidance, the 4 pillars of therapy for heart failure with reduced ejection fraction. To make this easy to remember, we use the mnemonic B.A.M.S. This isn't just a memory trick, it reflects the new clinical approach, starting all 4 therapies early rather than waiting to optimize one before adding the next. First, B for beta blocker. We're talking specifically about the heart failure licensed ones, carvedilol, bisoprolol, or nebivolol. These aren't just for heart rate control, they actually reduce mortality. In other words, patients live longer when these are used appropriately. Exam critical phrase, licensed beta blockers improve survival. Next, A for ACE inhibitor, ARB or ARNI. Traditionally, we started with an ACE inhibitor, or if not tolerated, an ARB. But now there's increasing recognition of ARNI therapy, sacubitril valsartan, which can be used in the right patients for even better outcomes. High yield buzzword, ACE, ARB or ARNI form the backbone of therapy. Third, M for MRA, mineralocorticoid receptor antagonist. That's spironolactone or eplerenone. They add an extra layer of mortality benefit, but with them comes the need for monitoring, especially potassium levels to avoid hyperkalemia. And finally, S for SGLT2 inhibitor. This is a relatively new but powerful addition. Dapagliflozin or empagliflozin. And here's the key point. They're recommended whether or not the patient has diabetes. Buzzword to memorize. SGLT2 inhibitors reduce admissions and improve survival across the board. So the key change in NICE 2025 is this. All 4 pillars should be offered early. There is no need to wait for full dose optimization of one before adding the others. In practice, this means patients get evidence-based therapy sooner, and in exams, it means the answer is always B.A.M.S, the full framework. Let's talk Entresto, sacubitril combined with the valsartan. When to switch? If symptoms persist despite the 4 main therapies, then replace the ACE inhibitor or ARB with Entresto. Buzzword to memorize, the 36-hour rule. Stop the ACE inhibitor, wait at least 36 hours before starting Entresto to avoid angioedema. And remember, never combine Entresto with ACE inhibitors or ARBs. Your takeaway line here, Entresto equals replace, don't add. On this slide, you can see 3 categories of heart failure management. Let's walk through them one by one. Number 1, heart failure with reduced ejection fraction, 40% or less. Here, we give the complete 4 pillars, a beta blocker, an ACE inhibitor or ARB or Entresto, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. This is the full evidence-based package for both survival and symptoms. Now, number 2, heart failure with mid-range ejection fraction between 41 and 49%. Think of this as the middle ground. We generally apply the same 4 pillars as reduced ejection fraction as long as the patient can tolerate them. The doses and combinations might need tweaking based on the individual, but the framework is still the same. And number 3, heart failure with preserved ejection fraction, 50% or higher. Here, we don't use all 4 pillars. The key therapies are SGLT2 inhibitors and mineralocorticoid receptor antagonists, which have been shown to improve symptoms and reduce admissions. So in summary, both reduced and mid-range ejection fraction can be managed with the 4 pillars, with mid-range needing a more tailored approach. Preserved ejection fraction is different. Here we use a more targeted strategy with SGLT2 inhibitors and mineralocorticoid receptor antagonists. Monitoring is absolutely crucial in heart failure management, and NICE 2025 has reinforced the key steps. Let's go through them clearly. First, pre-treatment assessment. Before starting any of the core medicines, you need a full baseline. That means checking renal function, sodium and potassium, and blood pressure. These numbers set the stage for safe prescribing. Second, early follow-up. After you initiate therapy or change doses, recheck everything within 1 to 2 weeks. This early safety net helps catch problems like rising creatinine or electrolyte disturbances before they become serious. Third, ongoing surveillance. Once the patient is stable, keep monitoring every 3 to 6 months. Pay special attention to mineralocorticoid receptor antagonists like spironolactone and eplerenone. Exam buzzword here is hyperkalemia risk. If potassium climbs and stays high, stop the mineralocorticoid receptor antagonist. And don't forget, Entresto, the ARNI, can also cause hyperkalemia, so monitor it just as closely as you would with ACE inhibitors or ARBs. Finally, loop diuretics. Think of furosemide here. It's effective for easing breathlessness and ankle swelling, but high yield phrase, symptom relief only, no survival benefit. Typical practice is 40 milligrams once daily in the morning with a maximum of 80 milligrams a day. Sometimes the dose is split morning and lunchtime. Always use the lowest effective dose, monitor weight, kidneys and potassium. And remember, diuretics improve comfort and quality of life, not long-term survival. So in practice and in exams, the message is clear. Check before you start, recheck early, monitor long-term, and keep a close eye on potassium, especially with mineralocorticoid receptor antagonists and Entresto. Let's talk about the medications we need to avoid in heart failure, and this is a classic exam area. The buzzword here is contraindicated agents. These are drugs that can actually make heart failure worse. First, calcium channel blockers. Rate-limiting ones like verapamil and diltiazem reduce the heart's contractility, meaning the pumping action is weakened, which is the last thing we want. Short-acting nifedipine is another to avoid because it causes reflex tachycardia, which can destabilize patients. Now, non-steroidal anti-inflammatory drugs, these are especially dangerous in heart failure because they cause fluid retention, reduce kidney function, and blunt the effect of diuretics. Put that all together and the risk of hospitalization rises significantly. But here's the important exception, amlodipine. If a calcium channel blocker is really needed, for example, for angina or blood pressure control, amlodipine is the safe choice. And here's your exam classic. Which calcium channel blocker is safe in heart failure? The answer is always amlodipine. All right. Time for a rapid fire recap. This is where we lock in the buzzwords. First, the mnemonic B.A.M.S. That's the 4 pillars of therapy, and the key point is they should all be started early. Next, NT-proBNP. If the level is over 2000, that means urgent referral within 2 weeks. Entresto comes with the 36-hour ACE inhibitor washout rule. Always remember that gap before you switch. Loop diuretics like furosemide provide symptom relief only. They help with swelling and breathlessness, but they do not improve survival. And finally, the avoid list. Non-steroidals, verapamil, diltiazem, and short-acting nifedipine. These are exam favorites, so know them cold. These are your exam anchors. Get them word perfect, and you will not miss the marks. And that brings us to the end of the NICE 2025 Heart Failure Update, all compressed into just 10 minutes. You now know the new treatment framework, the key safety rules, and the exam buzzwords that will carry you through both practice and assessments. The closing line to remember is this: excellence in heart failure management comes from evidence-based prescribing, vigilant monitoring, and locking in those high-yield buzzwords into your everyday thinking. If you've enjoyed this lecture, remember to give us a like and subscribe. It really helps us keep producing content like this. And one final bonus for you. If you would like a free copy of this entire lecture summarized onto a single A4 revision sheet, head over to our teaching website today. That's pharmacymasterclass.online. Download it for free and keep it handy for your revision.